Bismillah ar-Rahman ar-Rahim. It is my pleasure and honor to be with this gathering from very prestigious professors and colleagues from Egypt and Arab world. Today it is, I'm going to highlight the most important update for diabetic kidney disease. And the second part of the presentation will be highlighting COVID and diabetes relationship. So I was planning a short presentation, but I added some slides. So it will take 1 hour presentation and then 30 minutes for discussion if there is question or comment. To start with, we activated this part of the ESNT Virtual Academy, consulting the expert, and always we receive questions. So the questions that we received is about diabetes, kidney disease, and COVID. So I'm going to answer these questions to be uploaded later. So regarding the update of diabetic kidney disease, I would like to appreciate and congratulate Professor Nasrallah and Professor Ali Shindi for their excellent work last Friday. They highlighted the management of diabetes and chronic kidney disease by Professor Nasrallah and hyperfiltration by Professor Ali Shindi. I'm going in this slide to focus again and to stress upon what is mentioned about management of diabetes and chronic kidney disease. So this is the algorithm. And I think it is very rational and coping with that mentioned by Professor Nasrallah. Patients with a diagnosis of chronic kidney disease, the first line treatment is lifestyle modification and metformin, provided that GFR allows for metformin. Then, as you see, if still hemoglobin A1C is above the target, we think of the second line of treatment. The second line of treatment is nowadays is sodium, either to use sodium glucose cotransporter 2 inhibitors, and if this class of drugs is intolerated or contraindicated or GFR less than adequate, we can add or use glucagon-like peptide 1 receptor agonist. Still, we are out of the range, above the target of hemoglobin A1C. Third line will be thiazidine bioglitazone, but to be avoided in setting of heart failure or volume overload. Sulfonylureas, DPP-4 inhibitors, except sure saxagliptin, then basal insulin. So this is how we go through the management of diabetes and chronic kidney disease. Why this is the algorithm of management? It is based upon what is added to the literature in 2019 Credence trial that both kidney as the primary renal outcome for management of hyperglycemia by using canagliflozin. So this is why we find here the second line is sodium glucose cotransporter 2 inhibitors. And the second trial is Award 7 that focused on the use of the dulaglutide, which is glucagon-like peptide 1 receptor agonist, given weekly. In comparison to insulin, it was associated with preservation of GFR. This is why, after lifestyle modification and metformin, either sodium glucose cotransporter 2 inhibitors or the GLP-1 receptor agonist, the second line of management. Again, this is these are the two trials where the kidney is the primary target, and these are the clinical trials where they found beneficial effect on secondary endpoints for the renal benefits. Declare TIMI, so this is dapagliflozin. Rewind, it is dulaglutide. Canvas R, canagliflozin. Semaglutide in Sustain 6. Liraglutide in Leader, and the EMPIRIC outcome trial, which is well known to all of us. Here, the kidney beneficial effects were within the secondary outcome. What about modifications of anti-hyperglycemic drugs in chronic kidney disease? Let us take them one by one. Metformin. If estimated GFR is above 60 milliliter per minute, the maximum dose is 3 grams per day. This is the maximum dose. If GFR between 45 to 60, the maximum is 2 grams per day. Between 30 to 45 milliliter per minute, the maximum dose is 1 gram. Below 30, the drug is contraindicated. And if it is used, it should be used with expert and focusing on kidney function, and may request serum lactate and to be restricted to 500 milligram only. So this is what we agreed upon. Regarding sodium glucose cotransporter 2 inhibitors, the big dose can be given if GFR is above 60 milliliter per minute, and then to be restricted to the lower dose. Here, canagliflozin 100 milligram, if estimated GFR between 45 to 60 milliliter per minute. Don't initiate when GFR is less than 45, and it is contraindicated if estimated GFR is less than 30 milliliter per minute until we have an evidence to use below this cutoff point of GFR. The same for dapagliflozin, 5 to 10 milligram, not recommended if estimated GFR is less than 45, contraindicated below 30 milliliter per minute. 10 to 25 milligram, this is the dose of empagliflozin. And this drug, ertugliflozin, I think it is present in Japan, and the dose is 5 to 50 milligram per day when GFR is above 60, and not recommended if GFR is less than 60 milliliter per minute. So this is the dosages according to the levels of GFR. What about glucagon-like peptide 1 receptor agonist? Exenatide, this is the dose, 5 to 10 milligram twice daily if GFR is above 50 milliliter per minute. Used with caution, 5 to 10 milligram twice daily in this GFR range, 30 to 50, and not recommended below 30 milliliter per minute. Exenatide, this is the dose. Liraglutide, 0.6 to 1.0 milligram per day if GFR is above 15, but below this, it is not recommended. Dulaglutide, this is the advantage of dulaglutide. It is given weekly between 0.75 to 1.5 milligram per week if estimated GFR is above 15 milliliter per minute, and not to be given if GFR is less than 15 milliliter per minute. This is the modifications of sulfonylurea to be cautious, especially with long-acting sulfonylurea, because they are toxic and associated with toxic metabolite that can lead to hypoglycemia. And as we discussed with Professor Nasrallah, the only class of antidiabetic drug that has no nephroprotection is sulfonylurea. But the advantage, it is cheap drug. DPP-4 inhibitors, these are the members, sita, allogliptin, lena, vildagliptin, and this is a dose. All of them are modified except linagliptin, so we can use any of them provided that we respect the GFR. So we can use any member of these drugs if there is a degree of renal impairment, and we can take the benefit of modification to save the cost of treatment. But again, it seems that DPP-4 inhibitor is not of nephroprotective value, of significant nephroprotective value. TZDs, bioglitazone, it needs no dose modification, but we don't like this class of drugs in significant CKD because of volume overload. Insulin, there is no fixed formula for insulin, but we should monitor glycemic state to avoid hypoglycemia. Let us shift to one of the advances about the tubular hypothesis of hyperfiltration. So if we look here, in type 2 diabetes, there is increased expression of cotransporter, sodium glucose cotransporter 2 and 1, with subsequent increase in glucose reabsorption. and this will be associated with hyperglycemia and with the presence of many stimuli, either genetic, epigenetic, or environmental factor. With this increased work of tubular function, this will lead to tubular growth with subsequent damage, inflammation, and interstitial damage with subsequent diabetic kidney disease. This is a very interesting from the mechanistic point of view to show how sodium glucose cotransporter 2 inhibitors exert their nephroprotective effect. If we start from this point, this is the sodium glucose cotransporter 2 inhibitors. When we use them, this class of drugs reduces glucose and sodium reabsorption by the early part of proximal convoluted tubule. What will happen after this is increasing sodium, chloride, and potassium reaching this part of distal convoluted tubule, which is the macula densa, with subsequent improvement of tubulo-glomerular feedback and normalization of the abnormalities that occurred in afferent and efferent arterioles, and this will lead to afferent vasoconstriction and efferent vasodilatation with reduction of the GFR. Reduction of GFR will lead to amelioration of the work of the renal tubule and decreasing transport work by renal tubules, with subsequent reduction of oxygen demand by the renal tubules in the cortex. What will happen? This I want to just to focus on sodium glucose cotransporter 1. If we block 2, sodium glucose cotransporter 2, then sodium glucose cotransporter 1 will be activated, and this will reduce hypoglycemia. So this will increase glucose absorption by the late part of the proximal convoluted tubule, increasing glucose reabsorption, and the work of the distal part of the proximal convoluted tubule will lead to increased oxygen demand by this part of the nephron of the medulla. Increased oxygen demand will stimulate hypoxia-inducible factors that will lead to increased hemoglobin and hematocrit. Increasing hemoglobin and hematocrit will be associated with improvement of oxygen carrying capacity of the heart, improving the cardiac function, and natriuresis here from a reduction of sodium and glucose reabsorption will lead to a reduction of blood pressure. A lot of benefits exerted, and this is the mechanism of action. Reduction of the tubular function at the proximal, at the cortex, and increase in the part of the medulla, increasing the action in the part of the medulla will be associated with increasing hemoglobin and increased hypoxia-inducible factor that improve hemoglobin and hematocrit. And this is another article showing that there are several biomarkers for the use of sodium glucose cotransporter 2 inhibitor. At the end of the day, this drug, the class of drugs, work on glycemia, vascular tone, lipids, serum urate, adiposity, acid-base balance, kidney function, and volume. The most important parameter is volume. As I mentioned in the last slide, that hemoglobin is improved. This is, and with adjustment, increasing erythrocyte and reduction of blood volume and adjustment of volume status of the patient. Let us go to one of the most important practical segments within this presentation. How to use sodium glucose cotransporter 2 inhibitors and glucagon-like peptide 1 receptor agonist for management of diabetic kidney disease by the most applied algorithm that I liked it. To start with, we have diabetic kidney disease. In diabetic kidney disease, we want to know the level of albuminuria, either by urine albumin creatinine ratio or by protein creatinine ratio, as we discussed in the last meeting. If we concentrate on urine albumin creatinine ratio, if we are in A3, this means urine albumin to creatinine is above or equal 300 milligram albumin per gram creatinine. The second step is to look at GFR. If estimated GFR is above 30 milliliter per minute, and we have high level of albuminuria, then the first choice is sodium glucose cotransporter 2 inhibitor. And the GLP-1 receptor agonist may be added as a second line of treatment or to replace sodium glucose cotransporter 2 inhibitor if it is intolerated. So this is the most important point. Albuminuria, excessive albuminuria, with some preservation of GFR that allow us to use sodium glucose cotransporter 2 inhibitor. If estimated GFR is less than 30 milliliter per minute, no way we cannot use sodium glucose cotransporter 2 inhibitor. So we can use glucagon-like peptide 1 receptor agonist. And if we are in this value of GFR, we cannot use metformin as well. So if this is the first point. We look at urine albumin creatinine ratio, and after this, we look at GFR. If urine albumin creatinine ratio is not A3, less than A3, then we assess the risk for hospitalization for heart failure, high risk of hospitalization due to heart failure, with application of this algorithm. Just giving points to if there is prior heart failure, give 2, atrial fibrillation 1, coronary artery disease 1, GFR less than 61, urine albumin creatinine ratio, if it increased above 300, it is 2, urine albumin between 30 to 300 milligram per gram, it is 1. If we have 2 or more, this means this is a high risk of hospitalization due to heart failure. Here, we use sodium glucose cotransporter 2 inhibitor. If this score is less than 2, then we ask ourselves if the patient has high risk for atherosclerotic cardiovascular disease, this means the coronary or cerebral vessel problems, whatever the atherosclerotic disease, then we use either GLP-1 receptor agonist to control the metabolic profile because they are beneficial in this category of the patients, or to use sodium glucose cotransporter 2 inhibitors. Then, so if the atherosclerotic cardiovascular risk is there, GLP-1 is first, followed by sodium glucose cotransporter 2 inhibitor. If we don't have high risk for atherosclerotic cardiovascular disease, then again, what is the value of urine albumin creatinine ratio? If it is A2, between 30 to 300 milligram per gram, then sodium glucose cotransporter 2 inhibitor is preferred, and then GLP-1 receptor agonist may be used as an alternative or added on drug. If GFR is less than 30, then we can use GLP-1 receptor agonist. If there is no high albuminuria and no risk for heart failure, no atherosclerotic cardiovascular disease, and the albumin creatinine ratio is not A2, it's A1, so if we are here, we assess metabolic risk. If the patient is obese, if there is other problems, we can use GLP-1 receptor agonist is preferred over sodium glucose cotransporter 2 inhibitor as added on drug. If there is no metabolic risk and no obesity, then there is no indication for both sodium glucose cotransporter 2 inhibitors and the GLP-1 receptor agonist. I think it is clear. This is a heat map. This heat map, if we are here in this corner, this means we are in low risk for occurrence of end-stage kidney. If we are here, moderate. If we are in this corner, we are high risk for end-stage kidney disease. So if we are in low risk of end-stage kidney disease and urine albumin creatinine ratio is less than 30 milligram per gram and GFR is above 60, we can use sodium glucose cotransporter 2 inhibitor or GLP-1 receptor agonist. But if albuminuria is A2, SGLT2 inhibitor is preferred, then we can use GLP-1 receptor agonist as an alternative. But if albuminuria is A3, sodium glucose cotransporter inhibitor should be initiated, and the GLP-1 receptor agonist as added on for uncontrolled metabolic risk. If GFR between 30 to 60, and we are in this, so if we have GFR between 30 to 60, it is considered if we have albuminuria 1 or A2, this is a moderate risk for end stage, moderate risk. So in this, we can use sodium glucose cotransporter is preferred like here, like in this part of the figure. If albuminuria is A3, sodium glucose cotransporter 2 inhibitor should be initiated, and the GLP-1 receptor agonist as add-on for uncontrolled metabolic risk. But if estimated GFR is less than 30 milliliter per minute, here we cannot use sodium glucose cotransporter 2 inhibitor and the GLP-1 receptor agonist. And I prefer dulaglutide, because dulaglutide is given once weekly injection, until semaglutide, which is can be given orally, confirm the results of beneficial effect like dulaglutide and they become available in our market. We can use oral GLP-1 receptor agonist semaglutide. I think this is a very nice article. Shows clearly how to use both sodium glucose cotransporter 2 inhibitors and the GLP-1 receptor agonists. The most important point is how to use them safely. So should think of side effects. Here, genital fungal infection, it is well known from commonly reported in multiple large clinical trials. Severity may be low, so we should be careful. Keep genital area dry and clean. Prophylactic topical treatment for fungal infection in high-risk patients. So we should consider this point. Volume depletion is very important and crucial. And I think it is a mistake to prescribe sodium glucose cotransporter 2 inhibitor while the patient is dehydrated, because at the end of the day, they are natriuretic and they are diuretics. Proactive dose reduction of diuretics in euvolemic patient. Hold the sodium glucose cotransporter when patients have nausea, vomiting, or diarrhea. Implement a sick day protocol. Urinary tract infection is reported in a single large clinical trial. Use with caution if there is active UTI for patients with indwelling Foley catheters or self-catheterization. DKA, this is one of the most important points, usually neglected and underreported. And I think it is very essential to know. This is why I'm going to discuss this point later in this presentation. Amputation, it is reported in large trial, so encourage self-examination to reduce the side effects to early diagnose any problem. Bone fracture, it is reported in one trial, so caution in patients with risk of fall. Monitor beta H and vitamin D in these patients. Regarding GLP-1 receptor agonists, the major problem is the gastrointestinal tract. So patient education on symptom recognition, start a low dose, so start low and go slow, up titrate the dose over 2 to 4 weeks. Cholelithiasis and cholecystitis, patient education on recognition of symptoms to be assessed. Acute pancreatitis, severity is high, but it is reported in a small clinical trial or case series. Caution in patients with history of pancreatitis. So to put the safety signal in the mind. I think in the last meeting, in the last webinar of diabetes, Professor Saeed Khamis mentioned this case report. This is a case report where the use of sodium glucose cotransporter 2 inhibitor in this patient, 66-year-old man with type 2 diabetes, who was recovering from left knee septic arthritis and diagnosed to have acute kidney injury necessitating dialysis after the use of canagliflozin. So this is a case of acute renal failure, necessitated dialysis. If we are confronted by a case like this, what to do? To put in mind the diagnosis and to be confirmed by biopsy. And this is a biopsy. This is a BAS stain in low power and a high power. And I think it is clearly shows isometric vacuolization. And this is the oil red staining showing the lipid droplets This is electron microscope showing vascularization, and immunofluorescence for aldose reductase and fructokinase confirmed the diagnosis of osmotic nephropathy. To put in mind for differential diagnosis if we have acute kidney injury after the use of this drug. Now, is there a great difference between GLP-1 receptor agonist and DPP-4 inhibitors? This is an interesting data because it reflects large number of patients, 38,000 in each arm, in GLP-1 receptor agonist treated and DPP-4 inhibitor treated in Sweden, Denmark, and Norway. And this is the members of GLP-1 receptor agonist used, liraglutide, 90%. And as you see, this is the percentage of other GLP-1 receptor agonists. The most important message is the use of GLP-1 receptor agonists. This is the red line here, is the GLP-1 receptor agonist. It is associated, the use of this class of drugs is associated with significant reduction of cumulative incidence of serious renal events. So GLP-1 receptor agonists are superior to DPP-4 inhibitors for the sake of preserving kidney endpoints. And if we look at this detailed table for renal outcome, either primary or secondary, or the need for renal replacement therapy, or death from renal cause, as you see here, the hazard risk always less than 1 with significant reduction with the use of GLP-1 receptor agonist. So GLP-1 receptor agonist is superior to DPP-4 inhibitor, is more nephroprotective. And when they repeat the statistics according to different demographics, so subcategorical analysis, irrespective to sex, age, the presence of major cardiovascular disease, chronic kidney disease, always GLP-1 receptor agonist is superior and associated with lower problem and lower hazards in comparison to DPP-4 inhibitors. In the last meeting, Dr. Tariq Tantawi mentioned in his elegant comment that treating diabetes is the holistic, we should follow holistic approach. Exercise is mandatory, and this is one of the very important article, mini review, about the role of exercise training on diabetic kidney disease. We have two types of exercise. We have aerobic exercise, like walking, running, swim, and resistance, like the exercise to increase the muscle strength. So this is what is recommended for aerobic exercise at least 150 minutes per week, at moderate to vigorous for adults able to run steadily at 9.7 kilometers per hour for 25 minutes, 75 minutes per week. And the frequency, 3 to 7 days per week with no more than 2 consecutive days without exercise. So we should advocate aerobic exercise, and we should individualize the rate of exercise according to the patient tolerability for exercise. For resistance, moderate and vigorous, this is at least 8 to 10 exercises with completion of 1 to 3 sets over this time, a minimum of 2, but preferably 3 non-consecutive days per week. So we advocate both aerobic and resistance exercise, provided that we start low and go slow according to the patient's tolerability and to be well trained. What are the benefits of exercise on diabetes? In type 1 diabetes, aerobic exercise improves, as you see in this table, improves lipid profile, reduces insulin resistance, preserves endothelial function, reduce cardiovascular mortality. Resistance exercise, lower risk of hypoglycemia. So a lot of beneficial effects on type 1. And in type 2, many, many benefits for both aerobic and resistance exercise. Improving insulin sensitivity, improving lipid profile, improving pancreatic beta cell function, reduce the renal injury. We are nephrologists and microalbuminuria. Preserve renal function, so exercise delays progression of CKD in general, and especially in diabetic patients. Improve blood pressure control, but we are not going to do vigorous exercise with severe hypertension. It's better to control blood pressure first. Preserves endothelial function. And the resistance exercise improves glycemic control, reduce glycated hemoglobin, improve lean body mass, a lot of beneficial effects for both aerobic and resistance exercise on diabetic kidney disease. And this slide shows that exercise training, wise exercise training, is associated with improvement of metabolic and hemodynamic status of the patient through many mechanisms. I'm not going to read them, but improving inflammatory mediators, improving oxidative stress, mitochondrial function, cardiac output, renal vasoconstriction, endothelial function, all these points are improved by exercise. So please advocate exercise. What about diet? The diet, balanced diet is important, especially diet including larger amount of fibers. This is based on many studies, but here, this is from the update. This is a very nice experimental animal work. So this is type 1 diabetic rat model with streptozotocin. And then they tested diet with high fibers. And they knock out G protein coupling receptors. And the major result of this study is if we use high fiber diet, this will improve gut bacterial fermentation and gut microbiome with subsequent reduction of diabetic kidney disease in experimental fashion with preservation of G protein. So dietary fiber protect against diabetic nephropathy through modulation of the gut microbiota, enrichment of short-chain fatty acid producing bacteria, and increase short-chain fatty acid. So this is the point with the presence of G protein. How they know the effect on gut microbiome by studying RNA, ribosomal RNA sequencing of gut microbiome. Let us go to the clinical points away from basic and animal research. Is there a link between glycemia and stones? This is a cohort study with median follow-up of 4.2 years. This is the large number of Korean adults, 278,000 Korean adults. And through this follow-up period, approximately 7,000 participants developed nephrolithiasis. The most important and interesting data is in men. Look here at the level of plasma glucose less than 90, from 90 to 100, from 100 to 125. Less than 90 is the standard. Just hazards of stone is 1. If plasma glucose increases from 90 to just less than 100, the risk of stone increased by 5 to 23%, and it's significant. And in this range, it is more risk, more increasing in the risk. And if in the diabetic range, the risk is increased very much. What can we take for a message from this? In the adult men, we should encourage glycemic control even in pre-diabetic state. Any increase in plasma glucose above the normal value is not needed and associated with a stone, at least in men. In women, it was insignificant. Again, glycated A1C, even if it is in the range between 5.7 to 6.4, the risk of stone formation increased. This means that we should do our best for managing pre-diabetes, and it is better to educate people that pre-diabetes is just early stage of diabetes. It is diabetes in early phases. And there are many studies showing even renal pathology in pre-diabetic state. This is why I encourage to follow this position statement on screening and in management of prediabetes in adult in primary care. This is in Australia. How to follow? We have non-modifiable risk factors for prediabetes. Even if we don't take care of non-modifiable because they are not modifiable, we should concentrate on modifiable risk factors. So this is the education to overcome obesity and overweight. Unhealthy eating is bad, especially late at night. Insufficient physical activity and sedentary life is bad. Smoking is associated with many harm to diabetes and the kidney. Poor sleep is associated with sympathetic overactivity, high blood pressure, metabolic syndrome, dyslipidemia, medications, unnecessary use of medication that increase glucose. We should be aware of all these points to try to modify what can be modified to reduce development of diabetes. Now I'm going to highlight the addendum, what is added to the standard of care of the American Diabetes Association standard of care this year. What is added, this is one of the important points. FDA safety labeling recommends temporary discontinuation of sodium glucose cotransporter 2 inhibitors before any scheduled surgery to avoid potential risk for diabetic ketoacidosis. So I'm going to analyze this point, euglycemic diabetic ketoacidosis with the use of sodium glucose cotransporter 2 inhibitors. Why sodium glucose cotransporter 2 inhibitors is associated with euglycemic diabetic ketoacidosis? Because there is a great problem from the molecular point of view. This class of drugs increase, all the members of this class increase glucagon and reduce insulin because of glucosuria. Reduction of insulin and increased glucagon, this is the media for lipolysis and the ketone bodies formation. If ketone body formation is mild, this is beneficial for the heart, but the problem if it is exaggerated. So the type, we should know patients who are at high risk for euglycemic DKA. To avoid these points, low reserve of insulin secreting cells. So the patients with very low level of C-peptide are risky for euglycemic DKA. Patient at restricted food intake, we are giving these drugs and the patient doesn't eat. Patient at risk of hypovolemia. Patients with sudden reduction in insulin dose. Patient at increased requirement for insulin due to illness, surgery, or alcohol abuse. Patient with type 1 diabetes receiving the drugs off label. Patient with a hidden diagnosis of latent autoimmune diabetes of adulthood or positive for GAD65 antibodies. All these types of patients are risky for euglycemic diabetic ketoacidosis. If we add to this point that we are not following blood gases, and this means that the patient may be in risk for this syndrome of ketosis that is not associated with, I'm going to clear the drawing, it's okay. We should be careful for all these patients. How to prevent the euglycemic ketoacidosis? Withdraw sodium glucose cotransporter 2 inhibitors in patients scheduled to undergo major surgical procedures at least 3 days before surgery. The problem is these drugs may have long action, although their half-life is hours, but they can bind receptor for days. This is why it's better if we know that the patient will be exposed to surgery, to stop them 3 days in advance. Withdraw sodium glucose cotransporter 2 inhibitor in patients hospitalized due to serious illness. Use insulin instead of sodium glucose cotransporter 2 inhibitor in presence of other predisposing risk factors for DKA. How to treat if we diagnose? How to diagnose? If the patient presents with undue fatigue, the most practical and easy way is to order blood gases to know the level of bicarb. If the patient has acidosis and serum lactate is not high, this means euglycemic ketoacidosis. One of the mistakes is dependence upon urine dipstick for ketones. why it is a mistake? Because sodium glucose cotransporter 2 inhibitors increase renal reabsorption of ketone bodies. So the urine may show false negative results. So how to treat? If we wanted to assess ketone bodies, to assess them in blood. So if we, after diagnosing, stopping this class of drugs, ensure volume restoration by isotonic fluids and sodium chloride, 0.9%, potassium to be above 3.3 before starting insulin to avoid severe hypokalemia. Start insulin administration with continuous intravenous infusion. A change to intensive sub-Q regimen when acid-base balance is restored. Consider additional glucose infusion at the initiation of therapy because the patient is euglycemic decay because of glucosuria. Bicarbonate could be administered at high if the pH is less than 6.9, if we have severe acidosis. Ensure proper ventilation because bicarb therapy may be associated with hypoxemia. Ensure calcium supplementation because of the risk of tetany if we give bicarbonate. So the best message is to put euglycemic ketoacidosis in our mind as shown by FDA and added to the standard of management of the American Diabetes Association. If the patient is scheduled for surgery, stop this class of drug 3 days in advance. And if the surgery is prolonged, don't resume them except after resuming a regular diet for a few days. Another addendum added to the standard of care. This table within the practice guideline that was released in January this year showed 5 classes of anti-obesity drugs. One of them is this drug, selective serotonin receptor agonist. What has happened? FDA requested withdrawal of this class of drug. So weight loss drug lorcaserin is removed from the table of this table. This is the update. Why FDA stressed upon this point and the American Diabetes Association standard released and responded? Because of risk of increasing cancer by using this drug. So this drug is now obsolete and erased from the table of management of obesity. Another issue of metabolic surgery, weight loss surgery by gastric bypass. Although I advocate, whenever indicated, metabolic surgery, usually laparoscopic sleeve gastrectomy, but I'm going to present this data of gastric bypass, and this is an observational cohort study, was based on the merging of 2 nationwide quality registers in Sweden, the National Diabetes Register, and Scandinavian Obesity Surgery Register. 5,000 or more in each arm for gastric bypass group and for control group. What are the results? Look at the hazard risk for all renal endpoint. Halving of estimated GFR by MDRD or CKD epidemiology equation is significantly reduced. This means kidney is preserved significantly by metabolic surgery. Macroalbuminuria is significantly reduced. Acute kidney failure, significantly reduced. CKD is reduced. Diabetic nephropathy, severe renal disease, fatal kidney disease, cardiovascular disease, mortality, all these are reduced by metabolic surgery. So the message is we shouldn't be so delayed. If the patient is diabetic, hypertensive, and we maximize medical treatment and no response, please don't be delayed to advocate for metabolic surgery. I'm not going to recommend gastric bypass because of a lot of problems immediately after surgery, but sleeve gastrectomy is okay. And this is the results of this data. Macroalbuminuria red line is the metabolic surgery gastric bypass is significantly reduced. Severe renal disease or half the estimated GFR is significantly reduced. Congestive heart failure is significantly reduced. Everything is fine. by metabolic surgery, and the most important is quality of life. I think this is the last point in the first part of the presentation before shifting to COVID. Glomerular filtration rate and the bone health. With the reduction of GFR in a diabetic patient, we should expect bone disease. And to diagnose bone disease, we have to test for quantity, which is bone mineral density. DEXA, by DEXA, can all of us know bone mineral density. But usually we neglect trabecular bone score. Trabecular bone score is a reflection of bone quality. So both quantity by mineral density and the quality by trabecular bone score are essential to know if the patient will be in a risk for osteoporosis and fracture or not. And I think we got this lesson from Professor Amr al-Husseini through two elegant webinars about renal osteodystrophy, and the third one will be next month. The last point, metabolomic. Usually I don't like biomarkers because they are expensive, except if they are proven. This is a chronic renal insufficiency cohort study, including 1,000 patients, and they address 13 urine metabolites, plus age, race, sex, smoking, body mass index, hemoglobin A1C, urine albumin, and estimated GFR. And this is a quite busy table. But the most important conclusion, urine metabolites may, and whenever you find may, we can add by subconscious and may not offer insight into diabetic kidney disease progression. If replicated in future studies, aconitic acid and 3-HCG, and these are markers for amino acids and metabolic and mitochondrial function, could identify individual with diabetes at high risk for GFR decline. Up to this moment, only clinical parameters, estimated GFR, urine albumin or urine protein, blood pressure, smoking, obesity are vital, and we are waiting a magic biomarker. So biomarkers are still for research. Let us go rapidly to COVID-19. This is a study showing the clinical characteristics and outcome of patients with diabetes and COVID-19. Here I am stressing upon the first point. What happens to COVID-19 disease if the patient is diabetic? How diabetes affect COVID-19? Diabetes is associated with harm, with more severe disease, especially if it's associated with inflammation like high C-reactive protein. Again, diabetic patients with COVID-19 are at higher risk of ICU admission and poorer short-term outcome as shown by increased mortality. So diabetes increases mortality in COVID-19. Diabetes is associated with severity of the disease and poorer prognosis of COVID-19. Let us go to interesting point. What is the prevalence of diabetes among COVID patients? This is a meta-analysis showing that the pooled prevalence of diabetes is 9%. And if we categorize COVID patients into moderate and severe, the prevalence is 7%. The prevalence of diabetes is 7% in moderate COVID patients and 17% in severe COVID patients. This means COVID leads to diabetes. So COVID is diabetogenic. And this is the birth of term new onset diabetes in COVID-19. And the question is why? Why diabetes is associated with bad COVID-19 status and the COVID-19 is associated with diabetes? The link is bidirectional because the expression of AC2, which is well known for all of us, that it is a receptor for COVID-19, is present on many structures and organs responsible about glucose metabolism. So it is present on pancreatic beta cells. This is why COVID-19 disturbs beta cell and it can lead to insulin deficiency and diabetes and exaggerate diabetic problems even up to diabetic ketoacidosis. Also, it's present on adipose tissue, small intestine, and the kidney. All these are organs dealing with glucose. So this diabetic ketoacidosis is more expected with COVID-19. Type 1 diabetes and the COVID. Type 1 is associated with higher death, higher DKA, severe hyperglycemia if the patient is confirmed to be COVID. So COVID is associated with worsening of diabetic status. This is why nowadays there is consensus group to address recommendations and work on diabetes and COVID-19. Here I want to say acute hyperglycemia has been shown to upregulate AC2. If acute hyperglycemia upregulates AC2, this will facilitate viral entry to the tissues. And chronic hyperglycemia downgrade AC2. Downgrading AC2 will reduce AC2 more and more. And this will increase angiotensin 2, which is harmful. So acute hyperglycemia facilitates virus entry, and chronic hyperglycemia increases fatality and comorbidity. Another molecular point in diabetes is DPP-4 enzyme was identified as function receptor for human coronavirus Erasmus Medical Center. So DPP-4 can facilitate coronavirus. This is why there is at least theoretical interest in DPP-4 inhibitors, because DPP-4 inhibitors will target this point. This is why this consensus focused on outpatient care by this point, sensitization of patients with diabetes for importance of optimal metabolic control, optimizing of current therapy, caution with premature discontinuation of established treatment, utilizing telemedicine as we do. In patients or intensive care unit, monitor new onset diabetes and management severity of the diabetes. And I'm going to address this point in a minute. The therapeutic goals for glycemic state is this is the level of glycemia recommended, and it is better to follow continuous glucose monitoring as we can. And this is the plasma concentration between 4 to 8 millimole per liter from 72 to 144 milligram per deciliter. What about metformin? We are saying metformin, this is a great drug for diabetes. Is there a problem with using metformin in COVID patients? Let us discuss first these theoretical points of view. Metformin, what is beyond glycemia? Metformin works through this pathway, AMP kinase, and this will change the morphology of AC2, and this will reduce the entrance of the virus. So this is antiviral effect. And the second point, metformin is a drug that leads to mTOR inhibition. mTOR inhibition can lead to as well to inhibition of the virus replication. Also, metformin adjusts neutrophil, another beneficial effect. And this is an observational study between metformin group and no metformin group. Mortality is high with no metformin group if they have COVID-19. So it seems that metformin exerts some beneficial effects. Bioglitazone in people with type 2 diabetes with coronavirus, it is bone or bane, good or bad, ni'mah or la'na. This is theoretical. It is anti-inflammatory class of drugs, so it can ameliorate the inflammatory pathway in COVID-19. Let us go to the consensus management. For metformin, although theoretically may be beneficial, but be careful if there is dehydration and lactic acidosis for the patients who are dehydrated. So patients should stop taking drug and follow sick day rules if they are dehydrated. During illness, renal function should be carefully monitored because of high risk of chronic kidney disease or acute kidney injury that will add to the problem of using metformin. So in severe disease, metformin should be discontinued in COVID-19 patients. What about sodium glucose cotransporter 2 inhibitors? This is a bad class here. So although its use is rising in general diabetes, but in COVID era, we should be cautious, very cautious. Risk of dehydration and diabetic ketoacidosis is common with the era of these days of COVID-19. So they are not welcomed at all in COVID-infected diabetic patients or at risk of COVID infection. Patients should avoid initiating therapy during respiratory illness. Renal function should be carefully monitored for acute kidney injury. GLP-1 receptor agonist, dehydration is likely to lead to serious illness. So patients should be closely monitored. Adequate fluid intake is mandatory. DPP-4 inhibitors, as I mentioned from theoretical background, this class may be beneficial because it binds to DPP-4, which is the target for the virus. So these drugs are generally well tolerated. So if you ask me, what is the best class of antidiabetic drugs in the era of COVID-19, either to use insulin if the patient is severe disease in hospital with pneumonia, or if it's not severe disease, DPP-4 inhibitor may be used. So insulin therapy shouldn't be stopped. Regular self-monitoring of blood glucose every 2 to 4 hours should be encouraged, or better to have continuous glucose monitoring. Careful adjusting regular therapy if appropriate, therapeutic goal according to diabetes and comorbidity. And connected health models, telemedicine, take care of any of all these prophylactic points. What about metabolic surgery in the era of COVID-19? So this is Diabetes Surgery Summit recommendation for managing bariatric and metabolic surgical conditions for patients diabetic or not diabetic in the era of COVID. So the points, we have 3 points. Urgent access, this means to do surgery within 30 days. Expedited access means to be rapid, hurry to do the surgery within 90 days, or standard access doing surgery after 90 days. When to think of rapid surgery, if the condition was potential to deteriorate quickly in severe symptoms or dysfunction, examples of these cases, dysphagia, severe dysphagia, vomiting from anastomotic stenosis, symptomatic internal hernia. So these patients are operated and they have complications. So they are among urgent access to doing surgery. Expedited access for patients' condition are not likely to deteriorate quickly, but we have one of the following: substantial risk of morbidity or mortality, reasonable risk of harm, complex medical regimen, weight loss, metabolic improvement, or both are required to allow other time-sensitive treatment like organ transplant or orthopedic surgery. A standard access, if there are nothing of these, to be elective in selecting the case. So this is the algorithm. This is the algorithm for doing the bariatric surgery. We have either bariatric for diabetic, adjuvant bariatric and metabolic surgery, obesity surgery. So in diabetic surgery, according to the patient condition, if A1C above 8%, despite using insulin, history of cardiovascular disease, non-alcoholic steatohepatitis, albuminuria, stage 3 or 4 chronic kidney disease, more than 5 years of diabetes, here we be in hurry to follow expedited access. This means to do surgery within 3 months. But if we are following this column, it is hemoglobin less than 8%, A1C less than 8%, no history of cardiovascular disease, normal albuminuria, no evidence of significant microvascular, we are following the standard access. For obesity, for adjuvant bariatric and metabolic surgery, organ transplant needs to enable time sensitive for organ transplant, so we will be hurry. For obesity, a body mass index above 60 will be in hurry to be done within 3 months. So if the body mass index above 60 and more than 2 other metabolic abnormalities, and if we have chronic kidney disease stage 3 or 4. If we are less than 60, with these criteria, we can follow standard access. So if this is the recommendation, COVID-19 screening should be mandatory pre-operatively for patients considering bariatric and metabolic surgery. A laparoscopic approach, although it carries a risk for infection transmission, but it is more favorable than open surgery. Appropriate personal protective equipment is a must. What about RAS blockade? This is the, I think this is the most recent June Mayo Clinic, and it is not in diabetic in general. Because I received a question during Liverpool webinar, what about the use of ARBs? Because its inhibitor may be associated with dry cough, and COVID-19 is presented with dry cough. I answered, it is okay, it is logic. And then I find the conclusion here, ARBs could potentially be a more favorable treatment option in patients with COVID-19 at higher risk for severe form of the disease. I think the vision and mission, vision is to safe manage diabetic patient, avoid COVID-19 by applying all measures of personal protection and improving everything in the management and take care of the patient who has COVID. All these are points to put in mind. And I'm going to just, I have 5 minutes and stop. The drugs and their modification in the COVID era. Metformin, consider risk of lactic acidosis and hypoxia and acute illness. So should be discontinued in severe COVID-19 disease. Stop in severe illness in the hemodynamic instability or hypoxia. SGLT2 inhibitors are not preferred. Increased risk of dehydration, stop them in severe ill patient and moderate ill if they are intolerated. GLP-1 receptor agonist, expect gastrointestinal side effects and the risk of aspiration. Stop in severe illness. DPP-4 inhibitor, low risk of hypoglycemia, possible to use for a wide range of renal function, may be continued in non-critically ill patients. Sulfonylurea, risk of hypoglycemia if oral intake is poor or with concomitant use, stop them in this scenario. Insulin requires a frequent monitoring, and this is the drug of choice in severe illness of COVID-19. Continue ACE or ARBs, and there is some preference for ARBs, but monitor kidney function and monitor potassium, and if the patient is hemodynamic and stable, hypotensive, we stop them. Aspirin, risk of cardiovascular disease is higher during COVID, so continue for patients on aspirin for secondary prevention unless contraindicated arise. Statins, a possibility of increased risk of transaminitis and myositis is there, so individualized decision on the risk benefit and the benefit is needed. General precautions, hygiene and social distancing should be glycemic control, continue regular medication, regular glucose monitoring, ketone level monitoring in patients with type 1 diabetes or insulin type 2 diabetes, especially persistent hyperglycemic, healthy diet, physical activity, avoid smoking, stress management. This means holistic approach for the patients. What about the anti-COVID drugs or proposed anti-COVID drug? Although I don't like them at all, but if you use chloroquine or hydroxychloroquine, this drug may be associated with hypoglycemia. There are some randomized clinical trials to test hydroxychloroquine as anti-hyperglycemic drug and is approved in India as treatment of diabetes. Caution with insulin and insulin secretagogue. Prolongation of QT interval, with, especially if it is given with azithromycin. Lopinavir and ritonavir associated with hyperglycemia, deterioration of glycemic control, interaction with statin, increased risk of hepatic and muscle toxicity. Glucocorticoid increased hyperglycemia, susceptibility to infection. Remdesivir can lead to hepatotoxicity, so caution with statin and pre-existing fatty liver disease. What are the unanswered questions? I think this is the last point. Are people with type 1 with diabetes at increased risk of contracting COVID-19? We don't know. Is the presence of diabetes an independent risk factor for death in those infected? We want further studies, although it was shown in observational study to be associated with higher risk of death. Does type 1 diabetes increase the susceptibility to and or severity of COVID-19? It needs further studies. Does pre-morbid glycemic control predict susceptibility to and or prognosis of COVID-19? It is logic, but we are waiting results. Are SGLT2 inhibitors and ACE or ARB are safe? I think ACE or ARBs are safe in the moderate disease, and if the hemodynamic allows, and no problem in kidney function. but sodium glucose cotransporter 2 inhibitor are not welcomed in management of COVID disease patients. Are immune modulators or antiviral? I don't like them, and they need further evaluation. To close this presentation, we are living in COVID-19. A lot of gloomy and disasters are there, but I think there are a hope of collaborating together, meeting together, even through webinars, activating telemedicine, and respecting the health care workers and doctors and nurses, thinking of different technology and different manipulation of the patients. I think all these will be reflected in flourishing of nephrology practice. This is the ESNT Virtual Academy. I am very proud by this site because we had 28,000 users all over the world, and you can find here, this is the number, the circle reflects the number of users in Africa, Asia, Europe, North and South America, and even in Australia. And we added this sector consultant expert, and I hope that we can send the questions to all the experts who are joining this webinar to share us in answering the questions whenever we have compelling questions. The best to avoid COVID is to follow social distancing, even without mask, and to have a mask if we are in the crowd. This is mandatory. And at the end of my presentation, I hope safety for all of you. And I love you very much. And I am ready for any question. Thank you very much. Dr. Mu'tasim, would you please unmute any one of the attendees who raised his hand? And then at the end, we'll take some comments from the seniors. دكتور رمضان.
السلام عليكم دكتور حسين، ما شاء الله محاضرة رائعة كالعادة. I have only a short comment. I do agree 100% with you regarding the precipitating factors for DKA with SGLT2 inhibitors, especially the reduction in the dose of insulin, which sometimes is physician induced because of the fear from hypoglycemia. So the message for our colleagues to not to reduce the dose of insulin for patients who were initiated on SGLT2 inhibitors. The other etiology is hypovolemia or reduction of the fluid intake, as kindly you mentioned in your excellent talk. Some of our patients, they are worried by going to bathroom frequently for because of increased frequency of urination, so they reduce water intake. So this is another strong precipitating factors for DKA. The second,
I want to add a point here, Dr. Ramadan. If the patient is type 2 diabetes for a long time, I recommend measuring C-peptide. If C-peptide is low and the patient is in long-standing diabetes, so we should be very careful and to expect euglycemic ketoacidosis in this patients and even in type 2.
100% agreement, Dr. Hussein. The second point that DKA sometimes it can occur so much early with initiation of SGLT2 inhibitors. We have one patient started on one of the SGLT2 inhibitors, and she got severe life-threatening DKA after 24 hours. It is a case report about to be published, inshallah. It's within 24 hours without other risk factors except only reduction of the dose of insulin.
Was he one type 1 diabetes or type 2?
No, type 2. Type 2 diabetes. She was on
very nice case. Very nice case.
Yeah.
Okay.
Dapagliflozin was started, and within 24 hours, she has life-threatening DKA.
So this class of drugs are magic whenever used properly. So the problem is in the doctor, not in the class. If the situation of the patient doesn't tolerate, or this patient will be risky, why to prescribe them? So, and I'm stressing upon surgery. For patients who will be subject to surgery, stop them 3 days or 4 days before the elective surgery, and not to be resumed, especially for large abdominal surgery. I can wait even 2 weeks if I'm not sure if the patient will eat or not, because fasting is a real risk for ketoacidosis. دكتور سعيد.
مساء الخير يا دكتور حسين.
ازيك يا باشا؟ اتفضل.
الحمد لله. طبعا elegant as usual. بس كان ليا سؤالين. الاول بالنسبه للاس جي ال تي 2 انهبيتور، هل ليهم افكت بياند ان هم في الدايابيتيك بيشنت كرينو بروتكتيف في النون دايابيتيك بيشنت؟ دي نمره واحد. ولو كان ده اوكي، الناس اللي هم بياخدوها للهارت فيلير وهم مش دايابيتيك، هل في دراسات اتعملت على ان ده بيحسن الجي اف ار بياند ان الكاردياك اوتبوت بيتحسن؟ والسؤال الثاني بالنسبه لليوريك اسيد، ايه موقف اليوريك اسيد في الديفرنت اس جي ال 2 ميديكيشن والاذر انتي دايابيتيك دراج؟ شكرا.
Excellent points, Dr. Saeed. Thank you for these points. Regarding the first point, what was the first point, Dr. Saeed?
Non-diabetic patient.
Yes, to use them in non-diabetic scenarios. When I discussed this with experts in endocrinology and diabetes, I said to them, if the patient is not diabetic, I'll be very careful by using them. Although there are accumulating evidence from experimental animal studies and human studies, because DABA kidney that was prematurely terminated because of efficacy, and we are waiting in the full publication, included diabetic and non-diabetic CKD patients. And in other forms of chronic kidney disease, non-diabetic, there was a beneficial effect of using sodium glucose cotransporter 2 inhibitor in narrow scale. So they are beneficial through inhibition of inflammation, targeting inflammation, hyperglycemia. A lot of issues are there. Regarding uric acid, they are uricosuric, and this is another advantage for hyperuricemia. But be careful if the patient has uric acid stones. This is the second half, or this is the empty half of the cup. This is the bad face of the sodium glucose cotransporter 2 inhibitor, and this is one of the mechanisms of acute kidney injury by excessive uricosuric effect. So yes, they help uric acid, but this may be problematic in one case. So this is why we should follow the patient well. The third point, Dr. Saeed, in heart failure, DABA heart failure study, including diabetic and non-diabetic patients. But to be honest, I'm not sure if this was reflected on GFR on these patients. But I am expecting that this will be reflected on GFR by reducing the work, as I mentioned in the Nature review about the tubular hypothesis, that this drug reduces tubular work, improves oxygenation of the renal cortex, reduce fibrosis. From theoretical background, they may help kidney as primary prevention, but I cannot say this. They exert secondary prevention and primary prevention for cardiovascular disease, and I am expecting that this may be reflected on the kidney. Okay.
Okay. Thank you, sir.
Thank you very much. Who next? معتصم.
نعم.
هو
السلام عليكم.
وعليكم السلام. دكتور ياسر.
دكتور حسين. ازي حضرتك؟
اسلمك.
هلو. رائع كالعاده طبعا، متشكرين قوي، رائع كالعاده.
الله يسلمك.
Very elegant. Thank you. I have a question and a comment. My question about the use of statins in COVID. Do you have specific recommendations? يعني هل ان احنا to continue or ان احنا with the same precautions using مع liver enzymes، ولا حضرتك بتفضل ان احنا to discontinue in this era especially الفتره اللي هي بتاعت الاكتيف disease؟
I think I mentioned this but in indirect way. To be cautious if there is hepatitis or very high transaminitis. Or so in this scenario, I'm be reluctant in this point because the patient in critically ill state, and
that's سؤال.
if he is in critically ill state, severe pneumonia, C-reactive protein is high, ferritin is high, ALT and STs are high, so there's no need for statin in this point of time. But if there is if it is mild case and he is treated because he is diabetic atherosclerotic, like many people, like myself, so I continue taking statin if I don't have the disease. If it is mild disease, no problem in liver function, I continue. But in moderate to severe disease, I'll stop them. So this is a personalized medicine for statin.
Okay.
But so it is better to stop other drugs that may elevate the level of statin, like as I mentioned, chloroquine and other drugs that increase the level, and the antiretroviral drugs that increase statin. Increasing statin level may lead to transaminitis and rhabdomyolysis and renal failure.
Okay. بالظبط. شكرا يا رياض. بس ماي كومنت كمان احب اكد على كلام حضرتك، الهايبوغلايسيميا من الهيدروكسي كلوروكين.
اوكي. بالذات
البيشنت هي اندرجو داياليسيس، وقابلناها كتير قوي increased incidence of hypoglycemia during dialysis sessions في البيشنت بياخدوا كلوروكين مع الكوفيد. شكرا لحضرتك.
When I was in one of the locum in Saudi, Dr. الهويش, we had a case of severe hypoglycemia, and he mentioned that this may be caused because the patient was lupus nephritis and dialyzed, and she was continued on chloroquine. So he brought the possibility that this may be due to chloroquine. I reviewed this issue. I find it within the rare side effects, but I find a randomized controlled trial using hydroxychloroquine in comparison to other antidiabetic drugs for glycemic control. This means that they are with beneficial effect to the extent, because they are cheap in India, they use it as adjuvant for treating diabetes because of hypoglycemic effect of hydroxychloroquine. Dr. Muntasir.
شكرا لحضرتك.
الله يسلمك. I like to hear from Dr. Muntasir. Please unmute you, Dr. Muntasir. Yes, Dr. Muntasir. So the problem is there still. Thank you, Dr. So Dr. Faisal.
Yes, Prof. Hussein, it's excellent talk. I like it very much, and I like the algorithm, how you manage your patient with diabetes. And actually, personally, I get a lot today, and your excellent talk. I cannot add any more. I cannot even question anything because it seems to be clear, have algorithm, have some vision, which I like very much. Thank you, Prof.
But excuse me because of this long presentation, but I find the data exciting and interesting, so this is why I had it in long way. Dr. Tariq Anton.
Very good.
Dr. Tariq.
السلام عليكم، وسعيد جدا بالصحبه اللي انت عاملها النهارده. الكورسيرن بتاع الدايابيت طبعا دكتور مجدي، دكتور فيصل، دكتور منتصر، اظهر وبان،
دكتور مجدي. دكتور مجدي از وذ اس.
الزملاء طبعا اهو منور اهو بالريد كرافات. الكونسيرن بتاعنا بالدايابيتيك كيدني ديزيز بصراحه اكشوالي احنا في مشكلتين عندنا. المشكله الاولانيه اللي هي الاوبيزيتي، والاوبيزيتي لها تو بارت، عندنا الاكسرسايز وما عندناش اللكشرز ان احنا نعمل ايروبكس ولا سترينثنج اكسرسايز، فبالتالي اللي معانا الدايت ده اللي احنا ممكن نتناقش فيه شويه. انا سعيد جدا بالسلايدز بتاعتك ان احنا نهتم بالفايبر، وانا برضو مهتم ان انا اقلل الكربوهيدرات في الدايت بتاعي، مش ان انا امنع ولكن اقلل. بالنسبه للارمنتيريوم بتاع الهايبوجلايسيميك دراجز، انا طبعا بيوز الصوديوم جلوكوز كوترانسبورتر ان سيف مانر، وزي ما حضرتك قلت توظيفه بشكل مناسب للبيشنت very very important عشان تو مينيمايز الهازارد او سايد افكت. والادويه دي لها الكونسيرن بتاعها يناسبنا عشان الموضوع بتاع الاوبيزيتي ان هي بتلوز ويت. الدي بي 4 انهبيتورز برضو لها رول معانا وذا سيف دراجز. والموضوع الثاني بتاع الجي اللي بين جلوكاجون لايك بيبتايد ار اي انجكشن، طبعا في مشكله عندنا في البرايس وايز، ولكن هي طبعا مارفلوس دراجز ولها البينيفيتس اللي احنا عارفينها. سعيد جدا بالمحاضره ديت، وانت عملت لنا يعني ريفريشمنت وابديت اور نوليدج بداتا بتؤكد ان الكلام ده له بينيفيشال في الكلينيكال براكس بتاعنا. ميني ثانكس.
شكرا دكتور طارق. دكتور احمد عقل.
احب اشكرك دكتور حسين، والله يعني
بشكرك لوجودك، والله يعني سعيد بوجودك.
محاضره وحاجه ممتازه. انا شخصيا اتعلمت حاجتين، يعني الحاجه الاولانيه الدايابيتيك كيتو اسيتوزيس في تايب 1، واعتقد ان انت قصدك ان تايب 1 نبدا فيه الحالات اللي ممكن يحصل فيها دايابيتيك كيتو اسيتوزيس لما تبدا الصوديوم جلوكوز لينك ترانسبورتر.
لا تايب 2 ده المشكله في تايب 2 يا دكتور احمد. ده تايب 1 ده very risky، لكن تايب 2 ممكن يحصل فيه glycemic ketoacidosis if the patient will be subject to surgery and will be subject to long fasting. So the main problem also is there in type 2 diabetes.
بس تايب 1 انت ركزت عليه على اساس ان الانسولين ديفيشنت، الحاجه الثانيه اليورين اناليسيز للكيتو اسيدوزز، لما يكون العين بياخد الاس جي
بيبقى فولس نيجاتيف،
انهبيتورز بيبقى فولس نيجاتيف عشان الري ابزوربشن بتاع
الكيتون. مظبوط.
الحته دي يعني راعت انتباه، لان from the studies that insulin stimulates the SGLT2 receptors وبيعمل ريباوند ري ابزوربشن للصوديوم، وده يمكن one of the mechanisms that the in metabolic syndrome we always have hypertension with type 2 diabetic and certified as metabolic syndrome, and this mechanism can be alleviated by SGLT2 inhibitors. ودي تاني لينك يمكن اسمعها بينه وبين الجلوكاجون اللي حضرتك قلتها النهارده. احب اشكر حضرتك جدا على التميز يعني في اللقاء. دي كلها معلومات accumulate the knowledge in a drug looks safe but can have a lot of complications.
شكرا جزيلا يا دكتور احمد. طبعا استاذنا الدكتور مجدي شرقاوي very interested in diabetes and I'm very happy ان هو معانا النهارده. دكتور مجدي اتفضل.
طبعا بشكرك على المحاضره القيمه جدا يا دكتور حسين، وطبعا فرصه نشوف الدكتور احمد عقل والدكتور فيصل والدكتور طارق كلهم وحشنا يعني، وان شاء الله دكتور منتصر انا مش شايفه على الشاشه.
لا الدكتور منتصر اتكلم خلاص.
مستخبى
انا
بتكلم من الموبايل عشان عايز اشتغل معاكم يعني، فمش
ربنا يديك الصحه يا دكتور منتصر، ربنا يحفظك.
ان شاء الله بس الدكتور مجدي يتكلم وبعدين ليا سؤال يعني.
تمام. هو طبعا محاضره قيمه كالعاده، وطبعا احنا في الايرا بتاعت صوديوم جلوكوز، وحاليا بنحضر الاي دي اي لايف، ما عادش فيه بقى مؤتمرات. وكان في بريك ثرو ستادي اتقالت في الايرا قالت من 3 ايام، واتقالت في الاي دي اي امبارح على الانسنس اوف جي اف ار ديكلاين مع الكريدنس ستادي. كان حصل ان 10% ريدكشن في most patient في اول start of use of sodium glucose transport مع الكاناجليفلوزين. وكان حتى الكونكلوجن بتاعها ان we should ignore this change. يعني الكونكلوجن بتاعت الستادي ديت في الايرا اديتا، انا حضرتها في الايرا اديتا برضه، حضرتها في الاي دي اي. نفس السبيكر قال كل كتير من العيانين جالهم acute reduction of GFR، واحنا كلنا عارفين اللي هو الديب اللي بيحصل once we started this sodium glucose transport inhibitor. مش بس مع الكانا، كانت واضحه جدا مع الكانا في الكريدنس، لكن حتى في الفكره ان انا بؤيد تماما الدكتور حسين these are very good drugs و class of themselves وليهم very beneficial effects وهم promising regarding chronic complication of diabetes سواء cardiovascular او renal، ولكن we should be very cautious in this patient بالذات بقى كمان لو بدي معاهم diuretics، لو بدي معاهم ACE and ARB. وكمان الاخطر if I initiate these drugs together، ساعات العين بجيله بروح بديله صوديوم جلوكوز وبديله ايس وبديله ار وبديله دايريتك at the same time، وفي الاخر انا مش هبقى عارف الكلى هتبقى عامله ايه. بالذات ان برضو في الاي دي اي من ساعه كده كانوا بيتكلموا على البيكساجليفلوزين. البيكساجليفلوزين ده نيو صوديوم جلوكوز ترانسبورت انهبيتور، هو ما هوش نيو قوي، ستاديز بقى لها سنتين، لكن كان فيري بروميسنج افكتس على اللو جي اف ار، جي اف ار اقل من 30. كانوا واخدين بيشنت جي اف ار 24 ولقوا ان هو بيريديوس بروتينوريا وبيريتارد بروجريشن تو اند ستيج. البيكساجليفلوزين عكس الارتاجليفلوزين. الارتاجليفلوزين الستاديز بتاعته ثبتت ان هو مالوش كارديوفاسكولار بروتكتنج افكت رغم ان هو من نفس الجروب. فبرضه دي النقطه الثانيه اللي انا عايز اعلق عليها، it is not group effect. يمكن الكانا غير الدابا غير الامباجليفلوزين. وطبعا انا طبعا بايد الدكتور حسين في المحاضره. انا شايف ان الجي ال بي 1 هياخد ضوء اعلى بكتير في الايام اللي جايه، لان برضه رينال بروتكشن واضحه جدا وليه كارديو فاسكولار بروتكشن واضح جدا، وكمان حلو على الوزن وعلى الميتابوليزم كله في الدايابيتيك بيشنت. بالذات ان برضه انا ليا وجهه نظر في الدايابيتيك بيشنت، all diabetic patient should be considered diabetic kidney disease from the start of diagnosis. لان احنا we almost 40% of them لو عاشوا فتره enough هيجي لهم diabetic kidney disease by some sort of another، سواء جي اف ار decline او بروتينوريا. فلازم احنا يبقى الادويه اللي هننقيها from the start should protect the patient.
يعني الدكتور مجدي طبعا في الدايابيتس يعني زي ما هو في الكدني شديد هو في الدايابيتس شديد. I would like to stress on 2 points. اللي حضرتك النتائج اللي حضرتك بتقول عليها في الامريكان دايابيتس اسوسيشن والكلام ده، الكلام ده برضه اتنشر من سنتين او حاجه في الجاسن الكيرف السلوب كيرف، انه الايرلي، انا هقفل بس عشان الصوت الايكو، السلوب اللي بيحصل في الاول الريدكشن في الجي اف ار الاول ده زي ما بيحصل مع الايس والارب، بيحصل شويه ريدكشن في الجي اف ار، بس لو هو within less than 30% of baseline كرياتين او جي اف ار ما بقاش قلقان منه، بس بتابع واشوف على اللونج ران رغم ان حصل ريدكشن في الاول لانه بيقلل الشغل بيقلل الفلتريشن فده متوقع، وبعد كده بيبريزيرف لانه بيحسن الكدني ستراكشر، فده طبعا اكيد حضرتك فاهم 100%. النقطه برضو اللي افتكرتها دلوقتي، كان في احد السلايدز كنت بستخدمها من كام سنه كده، الكارما اوف جلوكوريتيك دراج، يعني الايثكس، فلو استخدمتهم في غير مكانهم ده يعتبر ان ايثيكال تريتمنت للناس اللي هم ديهيدريتد، الناس اللي واخدين كونكوميتنت. يعني عشان كده اضافه بس للكلام اللي كنا بنقوله مع الدكتور احمد عقل، انه ما ابداهمش مثلا في رمضان، يعني لو الواحد هيجي يصوم رمضان دونت انيشيت صوديوم جلوكوز كوترانسفيرز 2 انهبيتور وثاني يوم يصوم، ده لازم يبقى ستيبل عليهم عشان اسمح له يصوم. هم ما بيعملوش هايبوجلايسيميا، بس انا بخاف في الاكيوت ناتريسيس والدايوريسيس والايوجلايسيميك كيتو اسيدوز تحصل، فلازم العين يبقى ستيبل عليهم قبل ما اقلقه. فالكارما اوف جلوكوريتيك لازم، ده شغلتي انا كطبيب. والكلاس بتاعت الجليب 1 ريسبتور اجونست انا من الناس المؤمنين بها تماما، ولها بره الدايابيتيك كنترول حتى في الباركنسونيزم وغيره وغيره وغيره، لكن مشكلتها طبعا الانجكشن. اعتقد سيماجلوتايد لو بقى اورال، هو طبعا منه كان في فورم انجكشن وفورم اورال، الاورال بتاعه ده انا شايفه ماجيك، بس مستنيين فيرذر ستادز، رغم الاستادز اللي طلعت عليه استادز مبشره، لكن محتاجين فيرذر ستادز. على الاقل الدولاجلوتايد ثبت وجوده في الكدني ان كومباريزون حتى الانسولين بروتكت الكدني في الادفانس ستيجز اوف سيكيدي. فطبعا انا باكد على كلام الدكتور مجدي، وطبعا دكتور مجدي استاذنا. دكتور منتصر كان ليك نقطه عاوز تقولها. دكتور منتصر
اختفى.
لا يتكلم
كده حسين.
سامعك يا باشا، اتفضل.
You added to our knowledge today in COVID-19 is a diabetogenic drug in addition للكوكساكي بي فيروس والسايتوميجالو فيروس والأذر diabetogenic viruses. فهل في duration in between infection and appearance of type 1 diabetes؟ لأن الانفكشن with COVID-19 بيبقى identified واضح، غير الانفكشن بالاذر فيروس زي الكوكساكي بي والسايتوميجالو فيروس ما بيبقاش you don't know when infection happened. فهل الديوريشن between infection and appearance of diabetes في الستاديز اللي اتشافت ديت هل كان well defined؟
هقفل بس عشان الباك جراوند النويز ديت. للاسف ما فيش داتا تجزم الديوريشن امتى، يعني النهارده جالي كوفيد هيجي لي دايابيتس امتى؟ بس بتزود الريسك اوف دايابيتس، فيبقى بدل ما اشغل بالي بالتايمنج اوف دايابيتس هيحصل امتى، ما نمنع الكوفيد 19 ان انا ابعد خالص عن اللي هي ما فيش اكتر من السوشيال ديستانسينج لغايه الوقت. السوشيال ديستانسينج والماسك وين وي كومباين او وين وي ميت اتش اذر، والمفروض يبقى فيه 6 فيتس او مترين ما بيننا وبين بعض، فهو ده اونلي بروتكتيف واي. الفيروس حتى الثانيه ما حدش عارف الديوريشن ما بين الكوكساكي والكرنس اوف تايب 1 دايابيتس، ما حدش يقدر يجزم بها قوي. لكن الكوفيد لما بيحصل ويبقى في ديتوريشن وبيأثر على الاورجنز، بنتوقع ان الكورس اصلا من الريسبيراتوري ديزيز بيبقى غالب على موضوع الدايبيتوجينيك بوتنشال اللي موجود. لو الدكتور مجدي عاوز يضيف حاجه ابقى سعيد.
هو طبعا يعني انا برضو بايد كلامك، والجي ال بي 1 فيري بروميسنج، والسيماجلوتايد كان برضو في سيشن النهارده على الستادي بتاعته على الاورال.
تمام.
هو فيري بروميسنج دراج، بس هو برضه هيبقى فيري اكسبنسيف يا دكتور حسين.
طبعا اكيد.
المشكله ان هم فيري اكسبنسيف دراجز، وبرضه ما ننساش ان هم ليهم جي اي تي سايد افكت.
تمام.
يعني برضه
هو واخد
سايد افكتس،
هو واخدين بريفليج اللوراجلوتايد والدولاجلوتايد والسيماجلوتايد واخدين بريفليج ان هم يعني ايه لهم بينيفيشال افكت، وممكن اللوراجلوتايد بيستخدم لغايه 15 مللي بير مينت هو والدولاجلوتايد، لكن ما اعرفش السيماجلوتايد في السيفير رينال فيلير يستخدم ولا لا، مش مراجعها.
الليراجلوتايد كان في الاول ما طلع قالوا الجي اف ار
60 وبعدين نزلوه ل 30
نزلوا 30. اما الدولاجلوتايد
15
فادوه لحد دايالسيس.
بالظبط لغايه 15 لانه بعد كده
بس انا عايز اقول لك على الليراجلوتايد في الاناليسيز اوف ذا ستادي ان هو الرينال اوت كام بتاعه التوتال رينال اوت كام فيري جود، لكن لو عملنا له سيجريجيشن يا حسين هيطلع بس بريديوس بروتينوريا،
هو
حضرتك ديلي بروجريشن.
هو حضرتك بالنسبه للقصه دي النقطه دي اتراجعت في اكتر من ميتا اناليسيس، وبعضها اتعمل في رينال ويك السنه اللي فاتت وبعضها بيتنشر تباعا. ذا بيست كلاس على الكدني هي الصوديوم جلوكوز كوترانسبورتر 2 انهبيتور بيوند داوت، لانها شغاله على الدبلنج اوف كرياتينين والنيد لاند ستيج كدني ديزيز والنيد لريبليسمنت ثيرابي، فماسكه سوليد اوت كام كرايتيريا. الجليب 1 ريسبتور اجونست بتيجي في النص لانها ماسكه مودريت. الدي بي 4 انهبيتور عليها اختلاف، ده بعضهم ممكن يبقى له مشاكل وبكتيره بيقللوا الالبومينوري. فهو ذا بيست هي الصوديوم جلوكوز كوترانسبورتر انهبيتور، وعشان كده في الالبومينوريك بيشنتس هم فيرست تشويس اكسبت لو في عليهم تحفظات.
تمام، مؤيدك تمام.
انا بتهيألي احنا طولنا قوي، ويعني لو في اي سؤال انا تحت امركم، لو على حد عاوز يكتب على الشات او يتكلم انا ما فيش اي مشكله، علشان بس ما نطولش. انا يعني احب في الاخر بقى في الختام اشكر كل الاساتذه وكل زملائي اللي موجودين معانا. يعني انا مش عاوز اقول اسم وانسى اسم، بس دكتور فيصل ما دام فتح الكاميرا لازم اشكره، ودكتور طارق طنطاوي ودكتور احمد عقل ودكتور طبعا مجدي الشرقاوي ودكتور منتصر زيد وكل الزملاء والناس اللي سالوا واللي ما سالوش. وان شاء الله بكره الصبح الساعه 9 الصبح هتلاقوا الفيديو على اليوتيوب باذن الله. والناس اللي متابعين الدكتور محمد صبح بكره هيتكلم عن بودوثايتوباثي من الجينيتيك اند كلينيكال امبليكيشن الساعه 11 لو حد عنده تايم افيلابل في التوقيت ده. فميعادنا بكره مع الدكتور صبح الساعه 11 وبالليل مع الدكتور وسام الساعه 8 في بارت 2 من رينال ترانسبلانت باثولوجي. اشكركم واتمنى لكم الصحه والعافيه ونشوفكم على خير. مع الف سلامه.
السلام ورحمه الله وبركاته.